I'm really pleased once again to welcome Dr. Aravind S, who's a pathologist at PGI Chandigarh. He is already well known to this audience, having given previous lectures in this series of talks on renal pathology as a part of the India-Nigeria International Society of Nephrology Sister Renal Center program. He's with us once again in this monthly session today to talk about diabetic kidney disease. So without any further ado, I'm going to request Aravind to please start your presentation.
Thank you, sir. Thank you very much. So good afternoon all. So from India. So I'll just start sharing the screen. Yeah.
Great.
My screen is visible, sir?
Yes, it's all great. Thank you.
So, okay. So before going to the pathology proper, I'll just briefly tell the clinical details and pathogenesis of diabetic nephropathy. As we know that the diabetic nephropathy is one of the microvascular complication develops in approximately 30% of the patients with the type 1 diabetes mellitus and approximately 40% of the patients with the type 2 diabetes mellitus during the course of disease. And there is increasing prevalence of diabetic kidney disease. It parallels with the dramatic worldwide rise in prevalence of diabetes. So what is diabetic nephropathy? So diabetic nephropathy is a clinical syndrome characterized by persistent albuminuria. So that is the greater than 300 milligram per 24 hours. Okay, and there is steady decline in glomerular filtration rate and elevated blood pressure. So there are several risk factors in the pathogenesis of diabetic nephropathy. Some were categorized as susceptible risk factors, that is age, sex, and obviously the race and ethnicity. And there are some factors, initiating factors, including genetic factors and systemic conditions like hyperglycemia, obesity, and hypertension. And there are some factors play in progression of diabetic kidney disease. Of these, there are two most important risk factors is hyperglycemia and hypertension. So that one has to know. So the pathogenesis of diabetic nephropathy is very complex. It involves the interplay of many different factors. So I simplified in 4 steps. The most important the factor involved in the diabetic nephropathy is obviously the genetic factor, and the genetic predisposition to hypertension is an important factor. Although exactly we don't know the what genes are involved in diabetic nephropathy, but based on the family history, so that is documented that the genetic factor plays an important role. And the second most important factor in diabetic nephropathy pathogenesis is hyperfiltration. It is due to hemodynamic alterations. So this hemodynamic changes occurs as a result of intrarenal renin-angiotensin axis alterations, as a result of alterations in polyol pathway, or as a result of changes in prostaglandin synthesis, or increased reactivity to nitric oxides plays a role, in addition to hypertension. And the third most important factor is altered metabolic pathway, particularly as I told in this polyol pathway. And the formation of advanced glycation end products adversely affect the glomerular permeability and the accumulation of macromolecules within the glomerulus. And the final the factors are the various growth factors that also involve the progression of diabetic kidney disease. So here, we summarized the multiple factors involved in the diabetic kidney disease. So this is the schematic diagram. So that tells the initial pathogenesis of diabetic nephropathy. So the initial pathogenesis of diabetic kidney disease is increased glomerular permeability and increased glomerular filtration rate. So why it is happening? That is because of afferent vasodilation an efferent vasoconstriction. As a result, the pressure in the glomerular capillaries increased, so the glomerular filtration rate is increased. So this afferent vasodilation occurs due to hyperglycemia, high blood amino acid levels, and low sodium chloride delivery to macula densa. As a result of increased absorption occurs proximally. And this efferent vasoconstriction occurs due to local production of angiotensin II levels. So, I mean, as told, the first the pathogenesis involved in the diabetic nephropathy is increased glomerular filtration. So the Monk et al. The stage the diabetic nephropathy in 5 stages. So this classification came from the type 1 diabetic nephropathy. So here we can say that there are 5 stages: stage 1, stage 2, stage 3, stage 4, 5. And stage 1 starts with the glomerular hyperfiltration. So it presents at the time of diagnosis. As the years progresses, as the disease progresses, it goes to the various stages. The second stage is silent stage. So here also the glomerular filtration rate will be the normal, but it is characterized with thickened basement membrane and expanded mesangium in histopathology. And the third stage is incipient stage. It is characterized by microalbuminuria, that is per day. So this stage, I mean, lasts for 6 to 15 years. And the fourth stage is overt diabetic nephropathy. It is characterized by macroalbuminuria, I mean, that is subnephrotic range proteinuria. This more than 300 milligram per day. So it is for 15 to 25 years, and after 25 years of onset of diabetes, I mean, it finally results in end-stage renal disease. So, so this natural history of diabetic nephropathy starts from glomerular hyperfiltration and ultimately ends in. So through the natural history, pathological features, and pathogenesis of diabetic similar in both type 1 and type 2, but they are not identical. And 2/3 of patients with the diabetic nephropathy obviously develop renal failure, requiring either dialysis or renal transplant. So this another schematic diagram represents the evolution of diabetic nephropathy over years, starting with the increased glomerular filtration rate. As this progresses, the glomerular filtration rates declines and ends in end-stage renal disease. And we can also see that as the years progresses, the amount of protein in the urine is also increases. So, I mean, so similarly, I mean, in histopathological changes also varies with the time of biopsy after the onset of disease. It varies from the basement nearly normal glomeruli and mild basement membrane thickening to the progressive glomerular sclerosis. So we will see one by one. So before that, I mean, what is the indication of biopsy in diabetic nephropathy? So although there are no standardized criteria for kidney biopsies in patients with diabetes mellitus, so the authors in articles feel that the decision of performing renal biopsy is made by primary physicians. So this comment, I mean, I'll Raja sir or Vivek sir. Okay. So, but the basic indications for biopsy in diabetic kidney disease is early or rapid onset of proteinuria or nephrotic syndrome, early onset or acute or rapid progression of renal failure, the presence of hematuria, the renal failure with unusual nephritic urine segment, and substantial function without retinopathy, and the clinical features that suggest a concurrent disease such as lupus nephritis, post-infectious glomerulonephritis, thrombotic microangiopathy, acute tubular interstitial nephritis, and acute tubular necrosis. So, Vivek sir and Raja sir, any other indications for renal biopsies? I mean, you want to comment?
You have covered quite a few.
Yes.
But you know, in broad terms, whenever clinically we suspect that the person may have something else other than standard diabetic kidney disease, we should go ahead and confirm it by a kidney biopsy. Increasingly, there is a trend in actually trying to identify kidney diseases through kidney biopsy in people with diabetes as well. So, you know, the threshold for going ahead and doing a biopsy is coming down. On clinical grounds, whenever we see that someone has, as Aravind has mentioned, either rapidly progressive kidney disease, which is not consistent with the expected course of diabetic nephropathy, or that a person is presenting with unusual features such as hematuria, microscopic hematuria, or gross hematuria, or if a person doesn't have diabetic retinopathy, which is a very, very common accompaniment of diabetic nephropathy, then the suspicion for this being a non-diabetic kidney disease goes up. Also, if a patient has clinical symptoms suggestive of another systemic disorders, for example, like joint pain, fever, etc., which might suggest a connective tissue disorder, then we should suspect that something else might be going on. And the way to confirm that would include other tests, including a kidney biopsy. So those are the various things that we use in our clinical judgment to decide whether or not to do a kidney biopsy.
Right, sir. Thank you, sir. So just we'll move on. This renal biopsy should be evaluated by hematoxin eosin stain along with some special stains like periodic acid shift, Masson trichome, and silver stains for the light microscopy. So before giving a particular class, we should assure that the biopsy should contain at least 10 glomeruli. So excluding incomplete glomeruli along the biopsy. And definitely it should be interpreted along with immunofluorescence findings and electron microscopic findings. As on routine basis, so we use immunoglobulins like IgG, IgA, IgM, and complement C3, C1q, and light chains kappa and lambda to rule out other renal disease.
Arvind, I want to ask because electron microscopy is something which is not freely available. I know it is required, but is it synchronon, like, for diagnosing diabetic nephropathy, or even LM and IF should be more than enough for diagnosing diabetic nephropathy?
Yes, so to say class 1 diabetic nephropathy, definitely electron microscopy is to say class 1, so that diagnosis comes obviously from electron microscopy. So otherwise, other findings are very obvious on light microscopy and immunofluorescence.
So the message is like, class 1 usually we do not, the clinical indication biopsies is not in class 1. Yes, when we biopsy, it's usually of the higher stages, to be precise. Stages. Right, so even an LM and IF should be more than enough for diagnosing higher stages of diabetic nephropathy. Right. Am I right? Because
yes, sir, you're right, sir. You're right, sir. For the class 1, it's very important.
This information is important for them, so that is the reason I emphasize this. Okay.
And just to supplement and emphasize what Dr. Raja is saying, as I mentioned before, the idea is to pick up non-diabetic kidney disease rather than to necessarily make a diagnosis of diabetic nephropathy, right? So for picking up non-diabetic kidney disease, generally electron microscopy of the type that we think is not likely to be required. So light microscopy and immunofluorescence should be sufficient generally, except in some circumstances where the clinical suspicion is of a condition like Alport syndrome or something like that. Then you need electron microscopy if there is no other clue available from light microscopy. So I would say that the use of electron microscopy or the need for electron microscopy is likely to be exceptional rather than the routine in patients with diabetic kidney disease who undergo a kidney biopsy. Rather, kidney disease along with diabetes who undergo a kidney biopsy.
Right, sir. So thank you, sir. So that's yeah. So then this is the final point. The diabetic nephropathy should never be diagnosed without supportive clinical information. Okay, so if you are finding miscellaneous expansion, if the clinician is telling there is no diabetes, we should not make the class 2 diabetes. We should search for other diagnoses. Okay, so the patient should carry a clinical diagnosis of diabetes mellitus to apply this classification, what I am going to do. So this classification, so there are 4 classes of diabetic nephropathy. So class 1 and class 2 as subdivided into 2A and 2B and 3 and 4. So as I just told, the class 1 has mild or non-specific changes in the light microscopy. So the diagnosis comes from the electron microscopy. So here that is thickening of basement membrane, more than 395 nanometer in females and more than 430 nanometer in males. So this study was done in cohorts whose age group is more than 9 years. So we should see this age group also. So the class 2, we have to say when we are seeing the mesangial expansion. Okay, when we are seeing mesangial expansion, that is class 2, but without any nodule formation. When the mesangial expansion is very mild, we can see this class 2. When the mesangial expansion, I will just mention and when to say mild and severe in next slides. And the class 3 is represented by the presence of Kimmel-Still-Nielsen lesions, and the class 4 is advanced diabetic glomerular sclerosis. Okay, so that is glomerular sclerosis presenting more than 50% of the glomeruli. So to say class 4, I mean definitely we need 10 glomeruli. If you have only 4 glomeruli, I mean out of 4 glomeruli, if you are seeing only 2 glom, so we can't say this is this biopsy fits under class 4. So for that, to categorize under in these classes, we definitely need minimum 10 number of glomeruli. Okay, so the class 1. Okay, so the class 1, so this is a pre-diabetic condition. So here we can see only the thickening of basement membrane. Sometimes will be obvious on light microscopy, but mostly, I mean, the diagnosis comes from electron microscopy. So this thickening is because of extracellular matrix accumulation or increased deposition of normal extracellular matrix components such as collagens type 4 and 6, laminin and fibronectin. As already mentioned, I stress again, the thickness should be more than 395 nanometer in females and 430 nanometer in males, 9 years of age or older. If the patient age is less than 9 years, so we can follow this chart proposed by Haas et al. In this study of Alport syndrome and thin glomerular basement membrane. So this is the normal reference range of glomerular basement membrane in age groups less than 10 years. So as we can see here, so here this is normal glomerulus. So we can see the basement membrane, and so this is, I mean, outside, and we can see the podocytic process, and here we can see the fenestrations of the endothelial cells. So we just compare these two things. So what is happening here? So obviously that is thickening of basement membrane. Here we can thickening, I mean, is measured at the different levels. So here we can see that 1013 nanometer to 1423 nanometer. So this is obviously thickened, and here also we can see the mesangium is also expanded. And one more thing, what we can appreciate is the loss of trilaminar structures. We know that the basement membrane includes lamina densa rara, externa, and interna. So that distinction is not obvious in diabetic nephropathy. Okay. So the class 2, here the morphological changes are more evident. Okay, we can see the changes in even in light microscopy. So here we can see the two pictures. Okay, so one at the left. So here we can see that the mesangium is expanded. Okay, so when to say mesangium is expanded? Is there any criteria? Yeah, so we can say that when the mesangium is more than 2 nucleus thickness, so we can say this mesangium is expanded. Okay, so this is mild mesangial expansion. So when to say moderate to severe mesangial expansion? So for that we have to compare with the adjacent capillary lumen. If the mesangial expansion is more than the width of your adjacent capillary lumen, we can say that the mesangial expansion is moderate to severe. So those cases we can categorize in class 2B. So class 2A is mild mesangial expansion. That is the width of mesangium is more than 2 nucleus thickness of mesangial cells. And class 2B is the area of mesangium is more than that of capillary lumen. So the class 3, so the next class is class 3. To say class 3, at least we have to find one convincing Kimmel-Still-Wilson lesion. And obviously we should exclude class 4 before saying class 3. So that is, I mean, we should not find more than 50% of the glomeruli as globally sclerosed. So this Kimmel-Still-Wilson nodules appears both in type 2 and type 1 and type 2 diabetes. It can be focal, lobular, round to oval mesangial lesions with acellular hyaline matrix core rounded peripherally by sparse crescent-shaped mesangial cells. So we can say that center part of the nodule is acellular, whereas the periphery of the nodule is cellular. So that is mesangial cell. As a result of compression, the crescent-shaped nuclei is appreciated. So this is brightly eosinophilic, and it is this nodule is argyrophilic. The argyrophilic means it will be stained better on silver stains, and it is intensely PS positive, and it stains green with the Mason's trichome and blue with Mallory stains and black on Jones silver stains. So here we can see another couple of pictures of KW nodules. So, one more thing, what is the pathogenesis of KW nodules? So the two important processes are involved in the formation of KW nodules. The one is the lytic changes in the mesangial area, that is mesangiolisis, and followed by the detachment of endothelial cells from the basal membrane. How these two processes related is no one know, but as a result of these two processes, we can see that the microaneurysm, that is dilated capillary tubes in just adjacent to the nodules, were appreciated in few types of KW nodules. Okay, so these KW nodules are intensely blue on Mason's trichome stain and black on silver stains. And this is the electron microscopy of mesangial nodules. We can see that nodules with electron dense appearance on the electron microscopy. Is this nodules is specific only in the diabetes? No, it's not. The nodules can be seen in various glomerular lesions apart from the diabetes. So we can see the nodules in amyloidosis also, light or heavy chain deposition disease also, and organoid deposit disease like immunotactile, fibronectin, and collagenofibrotic also. And if the cause is not known, and we can label those cases as idiopathic nodular glomerular sclerosis. So we should also able to distinguish these other nodular glomerular lesions from the KW nodules. For that, we need obviously the special stains and electron microscopy. So nodular lesion, in case of light chain deposition disease and MPGN, the nodules will be very uniform. But in case of diabetes and amyloidosis, the nodules will be very irregular. Okay. So this is just, for pathological approach. And obviously, if the nodules are positive for congruent, so okay, we can think of, so this is amyloidosis, because amyloidosis obviously can coexist with the diabetes mellitus. So, if you have any doubt, if the nodules are not PS positive, if it is faint positive, we have to go ahead with the congruent stain to exclude the possibility of amyloidosis. As I told, these nodules are basement membrane-like material, so it will show intense black positivity on Jones stain. And in case of fibrinolactin, the fibrin will be positive. And in amyloid and collagen cases, as told, it will be PS negative or faintly positive. So this is just to distinguish how the diabetes can be differentiated from light chain deposition disease. So in light chain deposition disease, the nodules will be more evenly distributed, but in case of diabetes, the nodules will be asymmetric. Okay. Here the mesangial hypercellularity will be present, but in the diabetes, I told, the center of the nodules will be acellular, only the periphery of the nodules will be cellular. That too, the nucleus is compressed and gives the crescent shape. And coming to the special stains, and in diabetes, these nodules will be positive for PAS, Jones, and congruent is negative. And in light chain deposition disease, it is positive for PAS, but it is negative for Jones and congruent. So this is just to compare that. So here we can see this is the diabetic nodule. So it is irregularly placed, and we can see that central area is acellular. Okay, but the case on the right side, it is the cellular nodule. There are more number of nodules, and it is regularly placed, and it is cellular too. So one should know how to differentiate, and the amyloidosis, obviously it will be positive for congruent. So coming to the class 4, so class 4 implies that advanced diabetic nephropathy. And when we have to say class 4, if you are seeing more than 50% of the glomeruli in the biopsy or globally sclerosis, so we can say that, so we are dealing with the class 4 diabetic nephropathy. So the glomerular sclerosis in diabetic nephropathy is the endpoint of multifactorial mechanisms that leads to excessive accumulation of extracellular matrix proteins such as I told already, the type 1, type 3, type 4 collagens and fibronectin in mesenchymal spaces. So this is how to categorize the class of diabetic nephropathy in given renal biopsy. So we are getting the renal biopsy. So just first we have to count the number of glomeruli, and we have to count the number of glomeruli globally sclerosed. If the number of globally sclerosed glomeruli is more than 50%, then okay, so we can categorize that case as class 4 diabetic nephropathy. If it is less than 50%, then we have to look for any nodules is present or not in the biopsy. If you have even one nodules, that is KW nodules, so okay, so that is class 3 diabetic nephropathy. So if there is no nodules, then look for mesangial expansion, it is present or not. As I already told, the mesangial expansion, no more than 2 nucleus thickness. If it is present, yeah, this is class 2 diabetic nephropathy. Then see if the mesangium is more than capillary lumen or not. Yeah, the width of the mesangium is more than capillary lumen, then you can categorize as 2B. If it is not more than capillary lumen, then it is 2A. If there is no changes, but if the clinician is telling the patient is diabetes for some duration, then you went and go to see the electron microscopy. If the thickness is more than 430 nanometer in males and more than 395 nanometer in females, so you can say that this is class 1 diabetic nephropathy. So this is just a schematic diagram how to class the diabetic nephropathy on renal biopsies. So apart from this mesangial expansion, KW nodules, so we can see also there are different lesions in the setting of diabetic nephropathy. The most common and we can see the advanced disease is incidative lesions. So incidative lesions, I mean, it is because of the intramural accumulation of imbibed plasma proteins and lipids. If we are seeing in the glomerular capillary wall, so we can say that we can label that lesion as hyaline caps. It was previously labeled as fibrin cap also, but that is misnomer because it is not fibrin. It is just, I mean, imbibed plasma proteins and lipids. Okay, so this imbibed plasma proteins will show intense positivity on PSA, and this is very electron dense on electron microscopy. And this one should know that, so this also electron dense, so we should not take this as immune complex deposit. So one should know that, so this imbibed plasma proteins also can be electron dense on the electron microscopy. And if this incidative lesion is present in the Bowman's capsule, so that can be labeled as capsular drop. Okay, so the capsular drop and hyaline caps are incidative lesions, but the location of hyalinosis is different. Okay. So this capsular drop, I mean, although this is more specific for diabetic nephropathy, but it can be seen in other conditions, and it was described in other conditions too, in advanced glomerular disease.
And they are negative on immunofluorescence, right? The capsular drop and the hyaline cap, both of them.
Right, yes. So they are negative on immunofluorescence. Yes. Okay. So coming to the changes in the tubular interstitial compartment. So what changes we can expect in the tubules is in class, starting from class 2, so we can start seeing the thickening of basement membrane. So here we can compare with the normal tubules. So the thickening of basement membrane is very obvious without atrophy. Okay, so here also there is thickening is present. So thickening is normally can be seen in atrophic tubules, but here we can see that thickening even in non-atrophic tubules. So it is apparent from the development of class 2, but it become more conspicuous in class 3 and class 4. So this type of thickening without atrophy can also be seen in light chain deposition disease. That also one should remember. So another lesion that described in the diabetic nephropathy is Harmonic Extinguishing lesion. So this lesion is what? So it shows fine vacuolation. So that is lipids only. That is subnuclear vacuolation that is present in the proximal tubular epithelial cells. So if we are seeing this type of Harmonic Extinguishing lesions, we can say that, I mean, this patient also has nephrotic syndrome. So this lesion, I mean, although nowadays we are not seeing, but this was historically described in the diabetic nephropathy. And the changes in the vessels, so we know that the hyalinosis of the
Dr. Aravind, sorry to interrupt you. While you are speaking about vacuoles in the kidney tubules, it would be nice if you could tell the other causes of vacuoles in the kidney biopsies also, because that is important, technically for nephrologists.
Okay, sir.
Like CNIs, giving hydroxyethyl starch.
Yes. So in the setting of transplant thing, so first we have to see that the vacuoles are isometric or it is very coarse. Okay, if you are seeing isometric vacuoles in the setting of transplant biopsies, so first thing, I mean, we should think of CNA toxicity, the calcineurin inhibitory toxicity, not only in the transplant setting. I mean, if a patient is FSGS receiving tacrolimus for some duration, specifically the clinicians will ask, look for CNA toxicity. Okay, so if you are seeing isometric vacuoles, then we should think of CNA toxicity. If you are seeing coarse vacuoles, so that means that is seen in toxic ATN. So that can be seen in very different conditions because of toxicity like lead, mercury, like that. So if anything else you can add it, sir.
Okay.
I think there are other causes also, for example, osmolar.
Yes,
can you give mannitol, contrast agent, then hydroxyethyl starch, then sometimes massive proteinuria? Does it cause vacuoles in the tubules?
So massive proteinuria will not cause vacuoles. Massive proteinuria will cause protein resorption droplets only.
Okay.
But if lipid is also excreting, then we can see that vacuoles.
Right, and finally, conditions like hypokalemia also can cause vacuoles. Vacuolar nephropathy is what is described.
Right.
And also, look, just to complete the list of differential diagnosis in which we can see this kind of picture in the tubules, we should also keep in mind deposition diseases, right? Because in some deposition diseases also you can see deposits which can superficially look like vacuoles, although a pathologist will very easily distinguish that.
Right.
Rich Kamra here. So another reason which is kind of a coexisting proximal tubulopathy, which is non-crystalline, is one of the very common, is one of the causes of this kind of a vacuolation, because diabetic is quite common, and if that patient has monoclonal disease, that kind of a thing also needs to be kept in mind.
So maybe you can tell them a little bit. It is nothing but the light chains going into the tubule, so that is what you call light chain, light chain tubulopathies. Seen in plasma cell displasia. Yeah. Okay. And these vacuoles contain glycogen, Dr. Aravind?
In diabetes, it contains lipids, sir.
Okay.
Lipids.
Okay.
Oh,
wait.
It's right here.
I'm having a meeting. My sister will soon go.
Okay, so can I continue?
Proceed, Dr.
Yes, okay. So I mean, so we can also grade the lesion present in the biopsy. So based upon, so we can here see if there is no tubular atrophy and fibrosis, the score 0. If the atrophy is less than 25% in the biopsy, a score 1, and 25 to 50 score 2. And if the atrophy with fibrosis more than 50%, that is score 3. And also similar scoring and grading is also given for the interstitial inflammation. If the inflammation is present only in the IFTA region, the score 1. If the inflammation is also present in the areas apart from the IFTA, so that is score 2. And the vascular lesions like arteriolar hyalinosis, if you are seeing only at least if 1, so that is score 1. If you are seeing more than 1, then the score 2 can be given. So, and also similarly in the larger vessel arteriosclerosis, score 1 when the intimal thickening is less than the thickness of the media. The score 2 when the intimal thickening is greater than thickness of the media. So if you are seeing only the thickness of the media, and we can say that that can be due to hypertension. So we finished the light microscopy findings. So coming to any doubt in the light microscopy, glomerular lesions, tubular lesions, anything you can ask. Okay. So there is no doubt. You can go for the image.
Please carry on, Arvind.
Yes, okay, sir. Okay, sir. So immunofluorescence. So what we can see that is the linear staining for IgG. Here we can see the linear staining for IgG along the glomerular basement membrane and also the tubular basement membrane. So, I mean, the similar type of linear staining can also be seen in light chain or heavy chain deposition disease. So, in those cases, the albumin staining will help. Okay, if the albumin staining is also present linear on the glomerular or tubular basement membrane, then we can say that so this linear accentuation is because of diabetes mellitus, so rather than other glomerular disease. So this linear staining, one should, if you are seeing this type of linear staining, one should think so we are dealing with diabetes mellitus. Okay.
So what is the reason? Like, you know, the immunoglobulins are usually not there over there. So what is the reason this IgG gets deposited in a linear form?
So this literature books are saying this is because of advanced glycation in products. So it is deposit along the capillary wall and tubular basement membrane. So that might be
Picky.
AG, yes, sir.
Because of the glycation, the matrix is kind of altered, which becomes sticky, and that's why the immunoglobulins bind to it.
Okay, so in electron microscopy, as I already told in the different classes, subclasses. So here, what we can see is the thickening of the glomerular basement membrane, and the overlying food process shows effacement, near complete effacement, and it is accompanied by the mesangial expansion in advanced classes. So if you are seeing this, so these are the changes can be seen in diabetic nephropathy. And the one other changes initially I told is that loss of trilamina. So we can't able to distinguish the three layers, that is lamina densa rara, externa, and interna. So that will be very difficult to diabetic nephropathy. And in some cases, we can also use fibrilles. So that is will be distinct from the amyloidosis and fibrillary gene. So the diabetic fibrillose is also one findings that can be seen in electron microscopy. Okay, so these are the lesions specific to the diabetic nephropathy, what we saw till now. But I mean, as we know that non-diabetic renal disease can also occur in the setting of diabetic nephropathy. So one should aware of that, and one should look for those changes also. So these changes are independent of or superimposed on diabetic nephropathy. So that is various glomerular nephritis, pyelonephritis, papillary necrosis, and vascular diseases. So the reported frequency of non-diabetic glomerular lesions varies from 5 to 71% in different reports, depending on the criteria used to determine the necessity of the biopsy. But the occurrence of such lesions should be suspected in patients with rapid deterioration of the renal functions, persistent hematuria, sudden onset of nephrotic syndrome, especially before 8 years duration of diabetes, and in the absence of retinopathy, as already highlighted by Dr. Vivek sir. So the most common glomerular lesion in diabetic nephropathy is membranous nephropathy and acute post-infectious glomerular nephritis, that is PIGN, followed by IG nephropathy and different causes of crescentic GN. And the morphological pattern like focal proliferative, membranoproliferative GN can also be seen, and amyloid can also coexist with diabetic nephropathy. So for these reasons, so the light microscopy should be interpreted with immunofluorescence, and if essential and necessary, the electron microscopy also. So the second, the papillary necrosis. The papillary necrosis is increased in incidence at autopsy in diabetic patients in the recent days from 2.7 to 7.2% compared with the non-diabetic patients. So although the pathogenesis of papillary necrosis in patients with diabetes is due to several factors, the most common and important factor is relative ischemia due to vascular disease in diabetes, because the medulla receives only 8 to 10% of the total renal blood flow, and further reduction occurs at the tip of the papilla. So any additional decline, suppose dehydrations, that is pre-renal cause, so it has adverse consequences. And the second, the infection is thought to play a role in the papillary necrosis that occurs in the setting of diabetes. So the papillary necrosis occurs due to ischemia and infections. And one should know the other causes of papillary necrosis, as this is for the remembrance. I mean, usually we keep for the residents the post-cot. So the pyelonephritis, obstruction of urogenital tract, sickle cell disease, tuberculosis, chronic liver disease, analgesia, renal transplant, and diabetes, and systemic vasculitis. So these are the different causes of renal papillary necrosis. So this is one of our case. We can see that apart from the classical KW nodules, we can see the exudative lesions. The glomerular capillary loops are filled with the neutrophils, and it is also infiltrating the wall. So this is PAGN associated with class 3 and diabetic nephropathy.
Dr. Aravind, you can also tell them, like, HNE stain, is used because, like Madam had told in the introductory class, HNE stains are used to see for the cells, and so that's what we do.
Okay, so this is HNE stain. So HNE amatoxylin and eosin stain. So for seeing the inflammatory cells, what type of inflammatory cells, where it is exactly present. So for that, the HNE will be the better. And to see the capillary wall, basement membrane. So for that, so we have to rely on the PA stain. Okay, so this is HNE stain. So we can nicely see the neutrophils, bilobed, multilobed inflammatory cells present both in the capillary lumen, and it is also in the capillary wall. So this is, I mean, if it is present diffusely in the biopsy, we can say that diffuse proliferative glomerulonephritis. Okay, so diffuse means, I mean, it is more than 50%, involving more than 50% of the glomerular in the biopsy. So this DPGN pattern is, although it can be seen in other conditions, but it is classical of post-infectious glomerulonephritis. Okay, so this is another PA stain. So here we can see that the neutrophils are clogging the capillary wall, and it is also infiltrating the wall. Okay, so this is PA stain. Okay, this is PA stain. Okay, we can see the nodules are intensely positive on periodic acid shift stains. So the crescents, so if you're finding the crescents in the setting of diabetic nephropathy, first thing, definitely, obviously, we have to exclude other glomerular disease. So we have to see carefully the immunofluorescence finding, any C3 deposits or immune deposits present in the capillary wall or in the mesangium. If the immunofluorescence is negative, okay, so the crescents can be seen in 5% of the patients with the diabetic glomerular sclerosis who apparently have no other glomerular disease. The crescents might be due to the rupture of capillary wall. This microvascular injury occurring in the diabetic nephropathy. Okay, so these are the other changes occurring in the diabetic nephropathy. So few slides on the renal transplantation in diabetic nephropathy. The kidney transplantation is the best therapeutic option for the patients with the type 2 diabetes mellitus with end-stage renal disease. So in patients with the type 1 diabetes, we know that simultaneous pancreas and kidney transplantation has to be done. The earliest change in kidneys from non-diabetic donor when transplanted into patients with diabetes was the appearance of hyaline arteriolosclerosis. Okay, so as per the study, this hyaline arteriolosclerosis is the earliest change, and also the presence of linear staining of GBM for IgG and albumin is also can be seen early before appearance of mesangial expansion and nodules. And the studies also documented that the recurrence of diabetic nephropathy in transplant kidney occurs more quickly than required for for the native cases. That is, it occurs before 10 to 15 years. So that is the usual period required for the development of diabetic glomerulonephrosis in native kidney. Okay, so with this I conclude. Any doubts? Yeah, I will leave these slides.
Thank you,
This is important
Aravind.
for classification. Yes, sir. Yeah.
Raja, would you like to make any comments?
Sir, Onu was asking if you can just tell some clinical tips also, regarding diabetic nephropathy, so it is of use for the.
Why don't you go ahead and I'll supplement.
Yeah, sir. So I think Aravind has touched upon most of the relevant topics and when do you do a biopsy, what are the manifestations and what UTI complications. I think he has touched upon most of the things. But yes, I will try to, maybe summarize whatever he has told and we have discussed. So diabetic, in India, it is the most common cause of kidney disease. And I think in Africa also, I presume it's the diabetes which is the most common cause. And if you see, Aravind had nicely shown the 5 stages of diabetic nephropathy by Christensen and Morgensen, stage of hyperfiltration, stage of persistent hyperfiltration, microalbuminuria, macroalbuminuria, overt nephropathy. This is mainly for type 1 diabetes. In type 2 diabetes, it is not necessary it follows the same order because there are other factors other than diabetes like endothelial dysfunction, smoking, extensive atherosclerosis, which also predispose to the lesion. And you could move on from one stage to the you can skip a stage and move on to the other. So the classical 5 stages, the stages of microalbuminuria, macroalbuminuria, it is largely to type 1 diabetes. The next, this is the classification, which is mainly for type 1 diabetes. Then other than that is what are the precipitating factors or the risk factors for diabetes? Jasar had actually clearly shown that in one of his replies, he said there are something which is reversible, something which is not reversible. Something which is not reversible or irreversible is presence of race, genetic factor. Genetic factor means if your parents or one of your relatives have suffered from diabetic nephropathy, the patient runs or has a higher risk of contracting diabetic nephropathy if he develops diabetes. Then certain racial Indians, Pima Indians, and certain Latin American population are at heightened risk of developing diabetic nephropathy as compared to Caucasians. And the next is the reversible factors are the glycemic control, atherosclerosis, hypertension. So these are the usual reversible factors that you can do. And yes, the other things like protein intake, acute presence, if there is any, if you're taking any exogenous medications which could result in acute kidney injury. So these are the ones. These are the precipitating factors. Coming to the clinical manifestations, usually diabetes is silent disease, and whenever till the patient develops and very an advanced kidney failure, they are asymptomatic most of the times. Yes, most of the patients with diabetes would have hypertension. In type 1 diabetes, anybody with most of the patients with microalbuminuria stage itself would develop hypertension. With type 2 diabetes, it is even more commoner because at the time of diabetes diagnosis itself, 40% of the patients are hypertensive with type 2 diabetes. So when do you suspect non-diabetic kidney disease? Again, this was well discussed. One is with respect to diabetes and with respect to other clinical presentations. With respect to diabetes, like sir had told, when you do not have retinopathy, it is a general thing. You see, you can't see the kidneys, but you can see the microvasculature in other parts of the body, like the fundus. So one is there is no retinopathy, then you suspect there could be something other than diabetes, especially commoner in type 1 diabetes. Then there is massive proteinuria. So that is other thing. Then presence of hematuria, persistent hematuria. Some RBCs can be seen in 15% of diabetic nephropathy, but presence of lot of RBCs is not a feature of diabetic nephropathy. So these are the usual diabetic related. Yes, if the patient has got myeloma related. That is an anemia, anemia which is disproportionate. Then the patient has got electrolyte abnormalities, and patient presents with flash pulmonary edema, so and presence of a bruit. So, and these are the things where you suspect, these kind of non-diabetic kidney disease in patients with diabetes nephropathy, or in a patient with diabetes. So these are the things. And treatment-wise, there is one is preventive strategy and one is therapeutic strategies. Prevention is, we very well know that the best preventive strategy is glycemic control, which is time tested. We have large studies, DCCT for the type 1 diabetes, UKPDS for the type 2 diabetes, although those studies may not be very relevant today, but they go on to show that even, some period of intense glycemic control has got translation to microvascular and macrovascular benefit. So good glycemic control is one thing. Then the second one is use of certain medications. What are the medications? ACE-ARBs, AC mainly for type 1 diabetes evidence, and ARBs for type 2. It has gone on to show that they retard the progression from microalbuminuria to macroalbuminuria or overt nephropathy, and also progression of overt nephropathy to chronic kidney disease and end-stage kidney disease. Now there is a newer class of drugs called Sdlt inhibitors, that is sodium glucose transport inhibitors. So these are the newer class of drugs which have gone on to show that they also prevent development of microalbuminuria and also macroalbuminuria and chronic kidney disease in patients with diabetes. So, and there is one more class of drug which is aldosterone blockage. So these are like, previously we used to use spironolactone, which is a steroidal drug. So there is an increased risk of hyperkalemia and certain endocrinological side effect like gynecomastia. Whereas the non-steroidal drug Filrenone, which is a newer drug which has gone on to show that this also has got a protective effect in patients with diabetes with respect to the kidney disease progression, and the incidence of hyperkalemia, serious hyperkalemia, is less as compared to the steroidal antagonist like spironolactone. So mainly, and these are the therapies which you could prevent the development of diabetic nephropathy in patients with type 2 diabetes. And yes, hypertension control is something which you should not forget. The target of blood pressure in patients with diabetes is less than 130/80 millimeters of mercury. Although there are studies like advanced which has gone on to show that a blood pressure of less than 115/65 millimeters of mercury prevents development of chronic kidney disease as compared to somebody with blood pressure more than that value. But yes, in general, acceptable is less than 130/80 millimeters of mercury. Yes. And somebody says obesity, yes, weight loss does, reduce the proteinuria and has got an impact in development of nephropathy. So with this, I will stop, and it was just generally to give an overview of diabetic kidney disease. And if you take 100 patients of diabetes and do a kidney biopsy, this is a study which is published from Columbia University. I may not be telling you the exact percentage, but it is generally believed that 1/3 would have diabetic nephropathy, 1/3 would have diabetic nephropathy and non-diabetic kidney disease, and 1/3 would have a non-diabetic kidney disease. These are in patients whom you will go on to do a kidney biopsy for one or the other reason in a patient with diabetes.
Thank you so much, Raja, for covering a number of points during that short period of time. I think there have been more questions coming in the chat, which have been responded to more or less in real time by Dr. Tamra. A few I have tried to answer, and Raja, you have covered a number of points. But look, diabetes is perhaps the most rapidly growing cause of kidney disease in the world. And it's important that we recognize how to manage patients with diabetes and kidney disease. There is a lot of debate about the use of these different terms: diabetic nephropathy, diabetic kidney disease, and kidney disease in person with diabetes, because not all kidney disease in diabetes is simply because of raised blood sugar. That's important. And management of these patients requires a comprehensive risk factor based approach, not just management of glycemia. Blood pressure control is important, as Dr. Raja emphasized. Use of angiotensin pathway blockers, SGLT2 inhibitors are now coming up as perhaps the new wonder drug. And there is in passing also mentioned that maybe it should be added to the water of patients with diabetes. So those kind of, so which is all great news. Also other classes of agents are being tested, so we'll hopefully have more agents to help our patients with diabetes. But I think where biopsy comes into picture is that a lot of patients with diabetes are also not immune to developing kidney disease due to other conditions, right? So that's something which we know, especially in kidney disease related to plasma cell dyscrasias, which is not uncommon in people who are somewhat elderly. So that's something, those are the kind of things that we will miss if we don't do kidney biopsy. Although classical teaching is that patients who have diabetes and develop kidney disease are not biopsied, but I think we as clinicians, if we have to give good care to our patients, must be mindful of those situations where other conditions can be missed, and we should appropriately use a kidney biopsy. We do understand that full study of the kidney tissue to identify or rule out all conditions is not available in all parts of the world, and that is where you need to really be in touch with colleagues from other countries who have more experience in this. There is no shame in asking, so that we can offer the best type of clinical care to our patients. I think we have run out of questions in the chat at least, but we have actually gone over time. We started a little late. So any last minute questions? I think someone is saying type 2 diabetics do well with kidney transplant. Can't say the same with type 1 diabetics, especially if they don't get islet cell or pancreatic transplants. That is true. In fact, type 1 diabetics are extremely difficult to manage. And in resource poor settings, it is very rare that an individual with type 1 diabetes survives late into their 30s and 40s. It is uncommon. But increasingly, we need to recognize their complications early and manage them to the extent possible. Right. So I don't know whether Dr. Ifoma Ulasi is online or not. If not, then Onu,
I'm not sure she's online.
Yeah. Do you want to just make any concluding remarks before we close?
Yes, I really want to thank you for this exhaustive discussion and bringing it back to us clinicians that in as much as often assume that DM nephropathy is the same kidney disease once you see a diabetic patient, there are other things that we should look out for. And then the need for appropriate control of all their risk factors to be able to holistically manage the patient. So we want to thank you, Professor Raja and Davin, for this wonderful presentation. And we hope that we have all learned and we'll continue to chat and then continue with our discussions. Thank you very much.
Thank you, Onu, and thanks everyone. And we'll meet again in a month's time. Thank you very much, Dr. Aravind, for this wonderful presentation, which is deeply appreciated.
Thank you, sir. Thank you all. Thank you.